Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they'll be addressed in our Q&A session at the end of the presentation. I'm honored to introduce our mentor for today, Dr. Cheema. Dr. Cheema is an accomplished internist. She completed her internal medicine residency at the University of South Florida. She's also a mentor to students and a published author in neuroendocrine tumors and infectious diseases. Dr. Cheema participates in community services and believes in health for all. She is also running a clinic for low-resourced patients. So I'd like to welcome you, Dr. Cheema, and ask you to begin the session. Thank you.
Very good morning, everyone. Thank you, Robin. I really appreciate it. So let's start today's session. Today we'll talk about internal medicine, briefly about myself. I'm internal medicine, did my residency from University of South Florida. And I would like to start with why again. So as we discussed in our last session, find your why and start with why. The reason is when you find your why and start with why, how will it be easy for you? It will become very easy how you do it. So just focus on your why you're doing it. So we have to be very careful deciding. So I will talk briefly about it before we go over simulated case pretty quick. So today's I want to talk about, next slide, please. Briefly about myself, I will talk about it. Typically we talk, just remind ourselves for self-care, there will be a simulated case, and then at the end, keys to success. So now I'm going to talk about again, I would like to ask you, and I would like this session to be more interactive and would like participation. And it doesn't matter if you don't know the answer, just try your best and give your best educational guess. So I would like to know, why do you want to be in the medical field? I know this is the weekend, you guys woke up this morning to attend this session. So what motivated you? Why you want to be in the medical field? Let's see if we get any responses. The reason I'm asking you, because you will brainstorm, you will think about it, and it will give you the right direction, and it will make your path more easier. So you can spend your time, your energy, your resources in the right direction to achieve your life goals. So ask yourself, are you really passionate about doing it? I can tell you that you can do it, that you are passionate about it. How? As you all woke up this morning, attending this session all together, right? It shows your passion. It shows that you really want to do something in your life. You have some goals in your life that you want to achieve it. And you can spend this time with your loved ones, with your family, with your friends, but you dedicated this time to attend this live session. You're spending your time. You're spending your energy to gain experience, to learn, to polish your skills, to be good at what you want to do in your life. So remember one thing, your passion and profession should be the same. Why? If we review the history, if we go in the past, it was the passion that forced them to make a pen so we can write. It was the passion to make medicines, to make vaccines so we can cure the diseases and prevent the diseases. So it was a passion to make the aircraft so we can fly. So passion is what you enjoy doing it. So when you enjoy doing it, you don't get tired. So when we're passionate, we give our best performance, we deliver and make it life easier for others as well. So like when we write a pen, we never think, oh, wow, so amazing, right? Now it's a digital media. We can do a lot of stuff digitally, but of course, first thing was pen, then aircraft, we can fly, right? So they make our life easier. The medicines, the vaccines. So now given this pandemic, this vaccine when came in, we were so happy. Someone helped us, right? So do your best role that you can do in your life to serve the humanity. We all want to be success, and everyone has their own definition of success. And our success and strength comes with passion. It's all inside. Once you have a desire, it's a burning desire, find what's unique in you, because we all are unique. God has gifted everyone some unique talents, some strengths that make us different from the other. So no power can stand in front of you if you have a strong willpower to achieve your goals. With a goal of like, I can do it. I can do it, anything with a positive attitude. Of course, pain and challenges are part of the success track. Anything we do, it's a part, but when we understand that it will be a part of it, then we know how to manage. And it's being said, any work can make us tired. But if we love what we are doing we don't get tired. So if you're passionate, you love your work, it makes a out of time and space. So make your passion and profession the same. So you will not work a single day. So an excellence comes with passion. And passion also gives you energy. Passion doesn't look for the time. We don't look for any days off. We are so passionate, we say, okay, this is the thing, I have to do it. This is my goals in life, I have to achieve it. And you are fully focused in doing it. So passion is basically a driving force for progress. It can be at any age. When we get awareness, follow your passion. Execute the process to achieve your goals, and it becomes tangible. And the area of passion is to determine if, and don't have, when you are passionate, you don't have any limits. When you achieve one goal, you set up next goal. And it provides more options and opportunities. And do one thing at a time to avoid any burnout and not to be overwhelmed. And there is no scientific way to find out unless you do yourself. So you have to do experiment yourself. You have to try yourself, learn from other people's experiences, add mentors in your life. So how do you know that you're passionate about doing whatever you're doing? So keep testing yourself. Don't be afraid of doing experiments. So I can tell you a few symptoms, few signs that you can think, okay, I really am really passionate about it. I really want to do it. First thing, you enjoy doing it and you go out of space and time. And second thing, you feel like if you're not paid, or if I'm not paid for what I'm doing, we still do it. That shows a passion. I can tell you, I volunteered for a year without a single penny, and I love doing it. So it shows my passion that I really want to do it. I didn't care if I get paid or not. But at the end, of course, it's really rewarding. And you don't get tired while doing it. So even I can tell you, I was not making a single penny what I was doing as a volunteer in medical field. And I was really enjoying it. I never complained about it. So there's a very top artist named Michelangelo. He was a very good one who was making statues from the stone. And he was making such a perfect statues that it gives the illusion that it's a real person. He was a top artist, and he makes statues in the quantities for days, for a week or days, because he was out of space and time, because he loved doing it. So person should have same passion and profession. The reason why they should have, because the person who have same passion profession, they are more visionary. They develop the vision with the experiences and learn from their experiences outcome. VN is less like a VN-less person is like a blind person. So always have a VN in your life, have goals in your life. All right, let's briefly discuss about the grit. What is grit? Few responses I'm receiving. Let's see. Okay, let's move on. So grit is a significant indicator of success to achieve our goals. So grit is passion and perseverance for long-term goals. Why I'm talking about it? Because medicine is a long field. It's 4 years of undergrad, 4 years of medical school, 3 years of residency. Then if you want to do fellowship, another 3 years in cardiology, gastroenterology. So grit is having stamina. So grit is putting effort day in and day out, not just for 1 week, not just for a month, but for long term, for years, and working really hard to make that happen, to make your dream come true. So grit is basically living a life like it's a marathon, it's not a sprint. And the data shows that grit is unrelated or inversely related to the measures of talents. We all have talents. There's a really good book. There's how to find out your strengths. We all have top 2-3 strengths that we can polish and accomplish our goals. The idea built behind the grit is the growth mindset. So there are two types of growth: fixed mindset and growth mindset. So growth mindset people, they always achieve goals. And this is an idea developed by at the Stanford University by Carol Dweck, and she wrote a book on it as well. And it is the belief that ability to learn is not fixed, and that it can change with your efforts. So Dr. Dweck showed that when we read and learn, how it changes and grows our mind in response to any challenges. So they are much more likely to persevere when they fail. So it's normal. I have many failures in my life, but I never quit. So whenever you feel like you're down, you have some bad time, think about it, why you started first time. So never be a quitter. Think about it, learn from your mistakes, and move on. So because failure is not a permanent condition. So always being said, we never fail. Either we win or we learn. So growth mindset is the great idea for building the grit. And the grit is a passion and perseverance to achieve long-term goals. And grit is having stamina, said by Duckworth. So focus on your SMART goals. Focus is why you will focus. When you have a passion, you will be, excuse me, you will be out of time and space, and you will be fully focused to achieve your goals in life. So you have to focus what you want. You do not need to focus what you don't want. So find your passion, and then your mind and body won't get tired. And mind gives signals of tired when we get bored. But of course, take some break. If you feel tired, it's normal. We're all human beings. And start again. So just lesson is your passion and profession should be the same, and hard work always pays off. It never gets wasted. So I have a little acronym for doctor, right? I like this acronym. D for dedication. So basically, I say myself, doctor is a combination of strong habits to build up the habits. We are the creator of our habits. Habits make us. So D is for dedication, means you're committed to your task, our purpose of life. So when you find your why, you set your goals, you have a purpose of life. So you're committed to that goal, to achieve your goals with positive attitude. Then O, others above self. And then compassion. It means concern for the sufferings. It means you feel deeply for another person as they experience ups and downs in a life. We all experience ups and downs in our life, right? To be compassionate is not just tell someone that you care about them, but also to show them that you really care by being there before they even ask for it, and make their life easy. Always walk your talk. And T is for teamwork. Teamwork, together, everyone achieves more. And also teach others. And also T, I stand for treat and manage your patient the best possible way based on evidence-based medicine. And O is for offer solutions. R is respect human beings, regardless of their status, and be responsible. Responsible means we have ability to respond in any situation. So basically, it's a combination of our strong habits that we can adapt and stay positive in tough situations. Be hopeful. Be hopeful is a habit. Hard work is a habit. Planning is a habit. So divide your day. Make a plan. So divide your days, your weeks, your months, your years. Make a goals. 1 month goals, 1 year goal, 5 years goals. And divide resources intelligently. Your time, energy, resources. Plan them, choose them wisely. And value your time. Hard work is a struggle. Hard work is a habit. Struggle is a habit. So these are all good habits. And as I mentioned, habits make us, and adapt good habits to achieve your goals. All right. So how you discover your talent, how you discover your passion. Can someone type in the chat box? Let's see if we can see. Okay, yes. How do you know you're passionate about what you're doing right now, or whatever your goals are? How you discover your talent, how you discover your passion. So passion basically will not let you sit quietly. Nature gives you hints that you are made for this, do for this, go for it. So I can tell you 2-3 points that you can assess. You're passionate about it. This is your strength. You can work on it, polish your skills. It takes you out of time and space. You know, when we watch a good movie, any good movie, we don't realize the time. It passed by so fast, right? And we don't get tired. Even we keep watching movies back to back. We have 6 hours, 9 hours. We don't get tired. So this is how you have to find out what you're passionate about, how you discover your talent. This is how. And more you don't get tired. So first, you're out of time and space. You don't get tired. You earn the respect from that profession. And you don't care about the wages. You don't care about the fee. And it gives you happiness. It gives you joy. It gives you contentment. It charges you. It gives you energy. And when it gives you energy, you tackle any hurdles with open heart comes in your way. And you keep moving with passion. And you stay focused regardless of any hurdles. And always try to have your passion profession the same. All right. So there's a very good book I would like to share. It's called The Top 5 Regrets of Dying. It was there was one nurse in ICU. She worked for many years in ICU, and you know, in the ICU, nurses they see very critical cases. They have long hours staying in the ICU. It's very a challenging position, and of course, they help the critical patients. So her name was Bonnie Ware. So she interviewed a lot of patients in the ICU, and they asked them when they were on the deathbed, what are their regrets? So after interviewing multiple patients, she figured out the top 5 regrets of the dying people. And the one important was their passion profession was not same. They wanted to do something different, so they followed the trend. So it's very important to make sure your passion profession is the same. All right, so let's take a ride of internal medicine. Before taking the ride, you know, every time I remind everyone, talk about self-care, well-being, right? I know who are attending my prior sessions have on their fingertips now, but for new ones, I would like to go over pretty quick. And of course, as a reminder for myself as well, and for everyone. So why do we need self-care? We need to be compassionate with ourselves as well to avoid the burnout, to achieve our goals. And in medicine, as I mentioned, it's a long marathon that we need to be stay focused, keep ourselves healthy. And their self has 4 domains. I'll go over pretty quick. Physical well-being, emotional well-being, spiritual well-being, intellectual well-being, right? So pretty quick, physical activity. Can someone share with me what you guys are doing for your physical well-being? We talk about it in our prior sessions. So physical well-being, it's all about our body, how to keep our body healthy, because healthy body has healthy mind. So we have to make sure we have 4 areas as well to work on it. Physical activity, make a habit of regular exercise, consistent exercise, moderate physical activity. You can do for a walk, bike riding, keep moving. Then add nutritious diet in your food, adequate hydration, quality sleep, and mind your stress. And listen to your body, be compassionate. I already talked about, but pretty quick, there's a stress hormone called cortisol. It suppresses our immune system. So when our immune system is suppressed, we're more prone towards infections. So please be mindful and adapt some coping mechanism to help you with your physical activity. And now next is emotional health. Again, emotional health is basically about, there are 27 emotions, and it's very important and universal. There are 7 universal emotions. And basically, we need to learn how to keep ourselves well aware about ourselves, self-awareness. We call it self-actualization, knowing yourself. Then second is self-management, or we call it self-regulation. It comes everything, time management, study management, your courses management. It comes all of your finance management, your resources management, your self-discipline, and then social awareness. This means understanding of others, having empathy for others, meaning you have the ability to understand and share others' feelings as well. And the relationship management, keep up good relations with your fellows, with your family, with your parents, with your siblings, with your friends. And next one, I would like to share the mental health, IQ. It's basically, again, related to our vision. It includes verbal intelligence, it can logical reasoning, working memory, and processing speed. How we can improve? We can improve by read, and practice. Last but not least is our spiritual health. Spiritual health, it's the capacity of human being to know your purpose of life by self-understanding and understand the degree of compassion to human values, acknowledging your morality, fulfill your social responsibilities. We all have social responsibilities. And last but not least, attitude of gratitude, always count your blessings. All right, so this will conclude all 4 domains of well-being. And finally, please try to be physically healthy, emotionally sound, and intellectual by learning something new and find your purpose of life. So let's take a ride of internal medicine. I would like you to let me know, what do you think of when you hear the word internal medicine? Let's see how many responses we get this morning. All right, I'll give you some time. What is internal medicine? Okay, good. I saw responses from the prior question. That's really good. I really appreciate your responses. Doctors who need to know about all of the body systems. Okay, good. Teamwork in consulting other providers. Okay, good. All right, yes. So internal medicine basically is the physicians are the specialists. All right, knows a wide range of pathologies. Okay, all right, good. So internal medicine physicians are specialists who apply the scientific knowledge and clinical expertise to diagnosis, treatment, and compassionate care of adults. It's adult care. And basically, they are specializing in internal medicine, a discipline focused on the care of adults, emphasizing use of the best medical science available, called evidence-based medicine, caring for the patients in the context of thoughtfulness, meaningful, and the doctor-patient relationship. And Sir William Osler, he mentioned that the practice of medicine is an art. So basically, medical field is dealing with the diagnosis of medical conditions, make a plan of care plan, and then the prevention of diseases and compassionate care for adults. So physicians specializing in internal medicine are called internists. The most fascinating part of internal medicine to me, to diagnose and manage patients involving all the organ systems and a broad spectrum of healthcare issues and specialty. And this is a specialty that helped to train us to manage seriously sick patients as well. Like we have the rotation in ICU and CCU and the preventive medicine as well. So typically internists, we perform physicals, manage illnesses through medications. We do non-invasive methods, lifestyle medication, lifestyle modification with diet, exercise. And as I did internal medicine, it's a 3-year residency program, and it is extensive training. And we learn by doing different rotations. First year, we work as an intern, and the next 2 years, we work as a resident and work under attending physician supervision. So internal medicine rotation, we have both inpatient and outpatient. So internal medicine rotation include, we go for the medical floors. We will round in the morning, see the patients, admit the patient from the ER department. We have rotation in the urgent care as well. We have ICU, intensive care units, it's a medical ICU. Then we have a cardiology critical care unit as well. We have rotation in the emergency room as well. Then have outpatient care in the clinics. We have once a week, we had the rotations, we see our patients. So inpatient care, hospital setting, and outpatient care is office setting. And also there's we have the elective rotations where we have we can do electives in cardiology. We have rheumatology, dermatology, nephrology, endocrinology. So we have some electives that we can choose whatever we like to go and learn more about it. So once we complete our training, we can manage both inpatient care and outpatient care. So it's your choice, whatever you want to practice, inpatient, outpatient, or both. I do personally, I like doing both. It's called continuity of care. I see my patient in outpatient setting and then follow up patient in the hospital setting as well. So acute conditions, There are acute conditions and chronic conditions. So acute conditions we manage in the hospital setting, and the chronic conditions we manage in the office settings. And what is acute in medical terminology? So basically, acute conditions are severe and sudden in onset. These are the illnesses develop suddenly and last for a few days or weeks. Like you can think of appendicitis, like fracture of any bone, then sudden onset heart attack, any abdominal pain, any GI bleed. So these are all acute conditions that need to be managed in a hospital setting. And some acute conditions we can manage as an outpatient. Those are sudden in onset, but they're not severe. So we can, they don't need hospitalization, and we can manage in an urgent care setting and office setting, like simple UTIs, cellulitis, and the flu-like symptom we can manage. So chronic conditions are long-lasting, and they develop and potentially worsen over time, like Crohn's disease. Chronic conditions are developing, are long-developing syndromes, and that develop over a certain period of time. And chronic condition is a disease that is persistent or is for long-lasting. Like you can say osteoporosis, we manage, or diabetes mellitus, chronic kidney disease. So acute and chronic conditions are not necessarily fixed. Like acute conditions can sometimes become chronic. And while chronic condition may suddenly present as acute symptoms, like if we don't manage the acute renal failure, it can become chronic kidney disease or over a passage of time. Likewise, congestive heart failure, if it is not compensated clinically, a patient can have a CHF flare, and patient need to get admitted to the hospital for management, acute management of CHF. And such as like asthma flare-up. So these are asthma attack. It's a chronic disease, but sometimes you have flare-ups. So you need hospitalization with the close monitoring care. So this is how sometimes acute diseases turn chronic. And this is how we have chronic and acute diseases. And the most common cases I would like to share with you that will come across while shadowing internal medicine rotations, or even the ER, you will see cases. I would like to go over pretty quick with you. So patient with acute conditions go to the ER or go to the urgent care. And if you're shadowing any ER physician, so patient first encounters the ER physician. So what do they do? So they triage the patients, they do the history, they do examination, they do the diagnostic test, and the ER diagnostic test results come back very fast. And then treatment, they just stabilize the patient, and then they call the internists, the hospital medicine physicians. So we are, then our role comes in there. So we go to the ER, we evaluate the patients, and then we do the admission part, and then we continue care for next few days till patient get better, to be stabilized, to go home. So I would like to go over a brief overview of the internal medicine cases. So neurology. So neurology is a branch of medicine dealing with the disorders of nervous system, like central nervous system, peripheral nervous system, the blood supply of the brain, and the most cases we see in the patient were stroke. It's called cerebrovascular accident, sometimes transient ischemic attacks. So these are cases we see in patient. And then cardiology is a branch of medicine that manages disorders of the heart. The most common cases we do manage as inpatient rotation, we observe, you will observe and shadow as an internist in the hospital setting, the coronary artery disease called myocardial infarction, or called the heart attack. And then we manage congestive heart failure, CHF. Then we have atrial fibrillation. Atrial fibrillation is irregular heartbeat. Sometimes heart rate goes up in the 130s, 130s. So then patient need a hospital administration to manage with IV medication to help with the manage the heart rate. Then sometimes patient blood pressure is not well controlled, or they have missed their medications that call hypertensive urgency or emergency. They need hospitalization. So these are all the conditions we can manage in patient from cardiology standpoint. And pulmonology is a branch of medicine, manages disease of respiratory system. During this pandemic, the critical patients managed by the pulmonologists who need to be on ventilators. So during residency, we had the rotations, the medical ICU. Over there, we were managing patients with the ventilator settings. And but in the underserved area, when there's a shortages of physicians, attending physician, internists can manage the ICU patients as well, and they consult the pulmonologist. But in the big cities, they have critical care units. They have a dedicated staff for pulmonology, for pulmonary critical care service. So sometimes we don't need to follow up in the critical care unit in the ICU. And then there's a gastroenterology, it's a branch of medicine focused on digestive systems and its disorders. So conditions that we commonly need to be admitted in the hospital are a GI bleed, upper GI bleed, like patient have hematemesis, means that they are have a vomiting with blood in it. They have melena. Melena means when they pass the stool, they have blood in the stool. So we need to find the cause, and then we start a sportive care, and then we put the gastroenterology to be on board if need any scope. And then pancreatitis, patient can be admitted in severe cases, they need to be admitted in the hospital for the care. And then when they stabilize, then we can send home. And the cholecystitis and colitis, these are all the cases. Then nephrology is a branch of medicine that with the study of the kidney diseases, kidney function and kidney diseases. I know it's overwhelming, I'm going over pretty quick, but we will do cases one by one. Our next sessions, as you will have a better understanding and you will enjoy this, right? So then nephrology, again, cases are acute renal failure, then some there electrolyte imbalances, hyponatremia, hyperkalemia. So these are all the situations, nephrolithiasis, stones in the kidneys we can manage. Then endocrinology is a branch of medicine dealing with endocrine system. It's a disease specific, basically it's a secretions known as hormones release from our body. So endocrinology is a study of hormones. And then infectious disease disorders caused by the organisms such as bacteria, viruses, and some infections contagious. As we know, we are going through this pandemic. We are pretty much familiar about this, all the infectious diseases. And Dr. Green had a session a couple of weeks ago. He went over all the infectious diseases in detail. And then we have next dermatology, branch of medicine dealing with the skin diseases. It can be managed as an outpatient care settings. And then next is hematology. Hematology and oncology is a branch of medicine dealing with the study of causes of treatment and prevention of diseases related to the blood. And oncology is a treatment of the study of the cancer diseases. And then we have rheumatology. It includes the bones, muscles, tendons, ligaments, and soft tissues. So like I mentioned before, acute care, like patient had a fall, had a fracture, patient need to be admitted to the hospital. And of course, for joint replacement, any severe osteoarthritis need joint replacement, and patient need to be admitted to the hospital. And sometimes they admit to the medical floor, and we consult the orthopedic surgeon to be on board. All right, so next I'm going to talk about pretty quick the ENT, the ear, nose, throat conditions. It can be otitis externa, otitis media, rhinitis, sinusitis, tonsillitis that we can manage as an outpatient setting, but sometimes tonsillitis need a surgery, tonsillectomy, or any deviated nasal septum needs an ENT doctor to take care in inpatient setting and manage by a surgery. Then ophthalmology, we can manage conjunctivitis, stye, dry eye, blepharitis, but of course cataract, sometimes in glaucoma. These are the conditions that need to be in inpatient setting, and ophthalmology can manage those cases. And last but not least is prevention. For general, we can talk about falls, metabolic encephalopathy, arthritis, and the last but not least is the prevention. So all the immunizations, disease screening comes in the prevention. So these are all we can do in an outpatient care settings to manage patients. All right, so let's talk a little bit about the bedside manners before we take a ride of our simulated case. So I would like to, can you please go back? So this is the hospital care patient. These are called medical floors. These are you can see different rooms of patients, and there's a nursing station there. So in the morning we go see our patient, do rounds on them, and see the progress from the last day. And then we see any changes we need to do in medications. We make a plan, and then every day we assess how patient is doing. So this is how it looks like in the hospital care medical floors. All right, so let's talk about briefly the bedside manners before we take a ride of a simulated case we have today. So with good bedside manners, we can help our patients at our level best. Why when you talk about it? Before you enter the patient's room, take a pause and think about your patient, that how you can make your patient feel comfortable and help your patient to relieve the ailment at your level best. So when you go in the room, of course, knock the door, introduce yourself, call the patient by their last name, make them feel comfortable, build up the rapport, and use a layman's terms as much as possible. Don't use the medical terminology because we are so used to of all the medical terminology. Sometimes we bring up and it's hard for the patient to understand. and come on the right side of the patient. And communication is the key skill to your patient. It means how doctors interact with the patients through their tone, through the body language and the actions. It has a major impact on the patient's overall experience and understanding of their condition. Make an eye contact. So communication, listen to the patient. We should not tower the patient and sit down and have an eye contact level. And the eye contact shows the trust. It builds a connection, it builds a rapport. And listen attentively. Let your patient feel they are heard. So when you listen to the patient carefully, they give you the diagnosis. So they tell you all this details, give you all the story, what happened. Of course, we get all the details, and then of course we do the exam. So listen to the patient, they will give you the diagnosis themselves. And encourage an honest discussion. Allow them to explain their feelings. They're the human beings that we talk about emotions, right? So emotional health, emotional intelligence include listen to others, feel other feelings as well, put yourself in their shoes. And also, last but not least, be compassionate. The ability to convey genuine concern about patient's condition is an integral part of the medical communication process. All right, so let's move on. Let's start our simulated case. I would like to go over disclosure pretty quick. So this information is just for educational purposes. For students learning, please do not use this information for treatment for any medical condition. This is not a substitute for medical advice, as you should not disregard your physician's professional medical advice or delay seeking care because of something you have learned in this simulated patient case study we will do right now. And remember to call your doctor on 911 in case of emergency. All right, so let's talk about the simulated case. We have one patient. I can just briefly tell you about it. Her name is Miss Adams. She is 40 years old. Let's talk. I'm going to go in the room and we'll talk about it. It's a simulated case. All right. Knock, knock. All right. Hi, Miss Adams. Good morning.
Good morning, Dr. Cheema.
How are you feeling today?
I'm feeling okay.
All right, Miss Adams, how can I help you today?
I have a bit of pain in my stomach.
Oh, I'm sorry to know that. How long you have this pain?
For the last 4 to 5 months.
Oh, I'm sorry to know that. Can you tell me exactly where is the pain? Can you locate the pain for me?
I have pain here in the epigastric region and on the right side.
Okay, okay. So patient is pointing in the epigastric area, and you remember in the prior, I will just make a pause here, just to give you detail about the 9 regions, and patient is pointing towards epigastric. This is the epigastric area. The patient is pointing here. And flank area, the same patient is saying the right side. So this is the right flank. Patient is pointing out that I have a pain here. So I just paused here to let you know where is the epigastric, and this is the right flank area. Okay, all right. All right, thank you for letting me know. So how bad is the pain on 1 to 10 scale, as 1 is less pain on pain scale and 10 is considered the worst pain?
It's probably like a 5 to 6 on the scale.
All right, it is continuous pain or it comes and goes?
Some days it's continuous and other days it just comes and goes.
All right, can you please tell me, does it radiate to your back?
Not really.
Okay, all right. And how this pain feels like? It is a dull pain, achy pain, sharp pain, or crampy pain?
So it's overall dull in nature, but sometimes it's sharp pain on the right side.
All right. Any nausea or vomiting?
Sometimes I have nausea and indigestion, but no vomiting.
Okay. So how's your bowel movement? Do you have any constipation or loose stool?
There is constipation despite changes in my dietary habits.
Okay. Do you have any other concerns beside these symptoms you mentioned to me?
Yes, I have pain in my joints and bones, and I get tired pretty easily.
Oh, I'm sorry to know that. For how long you have these symptoms?
Pretty much the same time the other pain started, about 4 to 5 months.
I'm sorry to know that about it. So are you taking any medicine to help you with your symptoms?
Yeah, I'm taking over-the-counter Tums, Tylenol, and stool softener.
Okay, as you mentioned, you're taking over-the-counter medicine. Medicine helped you with your symptoms?
It just gives me relief for a while, but then the pain recurs.
All right. Did you notice any blood in stool?
No.
All right. And would you like to share your dietary habits?
Yeah, I try to eat a balanced diet like fruits, vegetables, fish, chicken, and I make sure to drink water adequately. And I added more fiber in my diet to try to help with the constipation.
All right. Did it help you with your symptoms, you mentioned a little bit, right?
Yeah.
Okay. Thank you for sharing. And it seems you have a very nutritious diet plan. To figure it out what's going on, we need to complete physical exam and blood test. Is it okay with you?
Yes, doctor.
All right. Thank you, Ms. Adams. Ms. Adams, I understand you're going through a lot. We will work together and make a best possible care plan.
Thank you, Dr. Cheema.
All right. So we will stop here. And I would like to go over differential diagnosis with you. Now it's your time to participate. It doesn't matter, you don't know, it's okay. Just go over what's going on. Patient mentioned she has a pain. Patient mentioned in the epigastric region and right flank pain. She mentioned 2 places has pain. She mentioned she has a bone pain as well. She mentioned she gets tired easily, and also she has a constipation. So these are different puzzles you have to put all together and make diagnosis what is a possible cause. You can give 5. Normally we make 3 to 5 differential diagnoses, and based on those we do the workup. So let's see. Okay, appendicitis. Okay, appendicitis or ulcers. Okay, let's see. I need more responses. Gallbladder stone. Okay, good. Yes. So liver issue. Okay, it sounds like a lot of symptoms in different regions of the body. Okay, yeah. So that's why I'm saying you have to think out of the box. So I would like to, I think I didn't add my slide. I would like to share the 9 regions of abdomen. So I mentioned 2 regions patient mentioned have the pain. Epigastric pain, this is the epigastric region. If you can see in the camera, I can show you. Epigastric is here, and right flank, this area. So you can see which organs are in these 2 areas. Okay, IBS could be a food intolerance even, okay? Something related to endocrine system. Yes, good. This I was thinking, think outside the box. So today's I'm going to talk about one topic about endocrine. So who said this? Endocrine system. Good. Okay, let's get more options. So what do you think in endocrine system? What's going on in the endocrine system? Hormonal imbalance. Okay, let's see. We get more responses. I would like your participation. Stomach acid issues. Yes, it's a possibility. Yes, you're right. Because I mentioned epigastrium. So epigastrium has stomach, has pancreas. So yes, you're right. It can be stomach, it can be pancreas. And what else? On the right side, we say liver, gallbladder, kidneys. Okay. All right. So let's go over. So this patient has today I'm going to talk about, I will not give you the diagnosis, but I would like to talk about the anatomy, physiology first, what's going on with the patient. And then I will give you the diagnosis at the end, but it's good. It's related, I can give you a hint, it's related to endocrine system. So you can start thinking your thought process on those lines. And yes, you're right. Differential diagnosis can be gastritis, pancreatitis, appendicitis. So these are the top differential. It can be hepatitis, but we have to think symptoms are long, 5 to 6 months. And the patient mentioned something else along with the pain, bone pain, and the patient mentioned constipation. So these are the things that we need to think, there's something else going on. And so I would like to talk about the parathyroid gland. So parathyroid gland is located in the neck over here. So I just go over pretty quick. This is the trachea, and this is the thyroid gland, this is the left lobe thyroid gland, right lobe. This is the larynx, the cartilage of and this is the anterior aspect, where you can see at the front. You can see my neck over here, right? So my thyroid is here, and this is the anterior. So the posterior part you can see over here. You can see 4 yellowish areas. These are the parathyroid glands. So parathyroid glands are 2 pairs of small oval-shaped glands. They are located next to the 2 thyroid gland lobes in the neck. I show you over here, the right lobe and the left lobe. So the posterior part, we cannot see it from the front, the back. So posterior is the back of the thyroid gland. You can see that these 4 parathyroid glands are embedded there, with small size oval-shaped glands. And they are located next to the thyroid gland in the neck. And each gland is about the size of the pea. And you can see over here, and again, detailed anatomy in the neck area. This is the thyroid gland. This is the artery, vein. This is the trachea. So this is the anterior part. If you see the posterior, you can see these 4 parathyroid glands look like embedded in the thyroid gland, right? So parathyroid glands are located in the neck, just behind the butterfly shape of thyroid gland. And most people have 4 parathyroid glands, which are 2 parathyroid glands lying behind each wing of the thyroid gland, as you can see in this picture. So I would like to go over briefly the histology. What is histology? The histology is the study of the microscopic structure of the tissues. So the reason I'm showing it to you, because I have to tell you the function of the thyroid gland. So if you know the histology, so you have a better understanding what's going on. So parathyroid gland have 2 distinct types of cells called chief cells. This white area you can see. So histology based in eosine and hematoxin. These are 2 pencils I know from my medical school years. We will keep drawing all the structures, whatever we see in the gross anatomy, we see under the microscope, and then we have to draw. This is how we retain in our hippocampus, stick to our hippocampus. This is another way of learning. So it was really a nice way. I'm telling the old school thought process, the way we were doing it. So this white area, you can see the adipose tissue, and you can see 2 different types, chief cells and oxyphil cells. And you can see the capsule, the outer lining. So chief cells, so parathyroid gland have 2 different distinct types, chief cells and oxyphil cells. So chief cells basically manage the secretion of parathyroid hormone. So what is the function of the parathyroid gland? So parathyroid gland secretes the parathyroid hormone. So I will go over briefly the physiology of the parathyroid gland. So parathyroid gland function is to maintain the serum calcium homeostasis through synthesis and release of parathyroid hormone. So I showed you the anatomy of the thyroid gland, parathyroid gland, and parathyroid gland secretes hormone called parathyroid hormone. Which cells secrete? Can someone type in the chat box? Which cells secrete parathyroid hormone? Let's see if you're paying attention or not. So I told you there are 2 cells, chief cells and oxyphil cells. Yes, so yes, very good. So you're paying attention, awesome. So chief cells secrete the parathyroid hormone, and parathyroid hormone function is to maintain the serum calcium in our body. So parathyroid hormone, I will go over pretty quick the physiology, this diagram, I'm going to explain it to you. So parathyroid hormones, basically parathyroid hormones affect the bones and then the kidneys. So then I will relate our simulated case after you understand better understanding of anatomy, physiology, pathophysiology. Then we'll go back to our case, what happened with our patient. So then you think, okay, this is a thought process behind all this case. So parathyroid hormone at the bone, it enables the osteoblastic activity and stimulate the osteoclast activity. So there are 2 cells, osteoclast in the bone cells, leading to the bone breakdown and release the calcium. So what is the calcium? So calcium is a mineral in our body. It needs to builds and maintains the strength of our bones and play important functions like maintenance of the bones and teeth. And we need to have a good calcium level. So almost all the calcium lies in the body is stored in the bones and teeth. So giving them the structure and hardness. And parathyroid hormone is mainly controlled by the negative feedback of the calcium levels in the blood. So who undergrad is right now doing biology or doing biochemistry or taking some endocrinology classes, they have a better understanding what we're talking about. So they have a negative feedback of calcium levels in the blood to the parathyroid glands. So what happens how we take the calcium? We take calcium from the dietary intake. So which food give us the calcium? Dairy products, milk, yogurt, cheese, fortified beverages, almonds, soy milk. So these are leafy green vegetables can give calcium resources, and the dried peas, beans, fish. So these are all I can think at the top of my head. And so that's why I talk about nutritious diet. So we need calcium every day. How much calcium we need every day? We need about 1,000 milligrams of calcium every day to keep our bones and teeth healthy. And of course, the amount need increases with age, like over age 50, I think need is 1,200 milligram per day. And for men over 71, it's 1,200 milligram. So basically calcium homeostasis, so parathyroid hormone is, we need it for calcium homeostasis. And it's a complex process having 4 key components: serum calcium, serum phosphate, vitamin D, and parathyroid hormone. So about more than 99% of total calcium is stored in the bone in the form of phosphate. and hydroxide salts. So how the parathyroid hormone affect on the bone? So what happens, I think let's go on the, well, let me see over here. Yeah, so this is the bone part, parathyroid hormone effect on the bones. And the osteoblast respond to the parathyroid hormone. So parathyroid hormone stimulates the bone resorption by acting directly on the osteoblast. It's also called the stromal cells, and then indirectly increase the differentiation and function of the osteoclast cells. So when this osteoclast activity increases, it releases the calcium and causes, you can see over here, the parathyroid hormone coming, this is the blood vessel. So this is the parathyroid gland releasing, the chief cells are releasing parathyroid hormone going in the blood cells. This blood cell bring this to the bone, then it activates the osteoblast, and then indirectly activate the osteoclast, releasing the calcium, and the calcium is going in the blood cell and the blood vessel, right? So this is how calcium is going in the blood vessel. Then second action I told you about on the kidneys. So kidneys, nephron is a function. I will go pretty quick the kidney function and glomerulus and nephron, so you have a better understanding how it affects on the kidneys. So nephron is a functional unit of the kidney, and the structure actually produces this nephron structure produces the urine in the process of removing waste product from our body and excrete the waste from our blood. And about 95% of the filtered calcium is reabsorbed along with the renal tubules. I will show you next slide. You can see this is a glomerulus capsule. This is the Bowman's capsule. This is the glomerulus. Bowman's capsule. Then this is a proximal convoluted tubule. So most of the calcium has been reabsorbed. So when it is filtered from here, it reabsorbs in the proximal convoluted tubules. And then loop of Henle, this is the descending loop, this is the ascending loop, this is the distal convoluted tubule, and this is the collecting duct. So this all compromised, you can see about 60 to 70% filter reabsorb in the proximal tubules, and by the passive mechanism, they can get absorbed in the blood again. So circulatory parathyroid hormone target the distal convoluted tubules. So where are distal convoluted? Here it is. You can see over here. So when parathyroid hormone reaches here, it targets the distal convoluted tubule and the collecting duct. So here's the collecting duct. So in the proximal tubule, there is already absorption by the diffusion mechanism. It has been absorbed from here, but parathyroid hormone is affecting the distal convoluted tubule and the collecting duct, and this is called this directly increases the calcium reabsorption. So parathyroid hormone decreases the phosphate reabsorption at the proximal convoluted tubule. So this is the two actions of the parathyroid hormone on the convoluted tubules. So how it affects, I will go back to the picture again. So I told about the action, how parathyroid hormone acting on the bone, how it affecting on the kidneys, but how in the intestines, what's going on over here. So parathyroid hormone indirectly increases the calcium absorption from the food in the intestine via its effect on vitamin D metabolism. So what happens? So in the intestine, there's an enhanced absorption of the calcium from the small intestine. It facilitates the calcium absorption from the small intestine, and it will serve to elevate the blood levels of the calcium. So parathyroid hormone stimulate this process, but indirectly stimulating the production of active form of vitamin D in the kidneys. And when there's increased vitamin D, it causes increased absorption of calcium in the intestine. This is how it works. All right, so next I'm going to talk about what's going on. So you understand all the anatomy, physiology, and now I'm going to go next, what's going on with what parathyroid hormone is doing it. So next, all right. So I would like to talk about the primary hyperparathyroidism. What is hyperparathyroidism, first of all, right? So I will relate in our stimulated case, what happened in our scenario. So I talk about the parathyroid anatomy, physiology, now hyperparathyroidism. As we mentioned, that parathyroid hormone release the hormone called parathyroid hormone, which cells? Chief cells, right? They release a hormone to affect the kidneys, bones, and intestine to absorb the calcium. It's normal homeostasis. But what happened in the hyperparathyroidism? Hyper means increased level of parathyroid hormone. So in the primary hyperparathyroidism, one or more of the parathyroid gland is overactive. How it become overactive? They should, as I mentioned, there's a negative feedback. When there's low calcium level, it senses, then it releases more parathyroid hormone, then it goes affect the bones and kidneys, absorb more calcium. So now what happens in the primary hyperparathyroidism? The parathyroid gland is overactive. As a result, the gland makes too much of the parathyroid hormone that we don't need. So too much parathyroid hormone calcium level causes increased calcium level in our blood. So in calcium level rises. So what happened when the hyperparathyroidism causes hypercalcemia? So I will go over all, there's a different types: primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. So primary hyperthyroidism is basically the unregulated overproduction of the parathyroid hormone, resulting in the abnormal calcium homeostasis that causes the hypercalcemia. Hyper means increased calcium level. All right. So the other terminology is hypocalcemia. So hypo means low levels. Likewise, hypoparathyroidism means parathyroid level is low. But today we're going to talk about basically the primary hyperparathyroidism. So how frequent we have this? The primary hyperparathyroidism is more common in women, and the incidence is about 66 per 100,000, and in females, and about 25 in 100,000 in men. So what are the causes? So causes of primary hyperparathyroidism is abnormal growth, any abnormal growth. It can be adenoma. What is adenoma? It is a non-cancerous growth on a gland. You can see over here in this picture, you have this yellow dot showing the parathyroid gland. And this area is a single parathyroid adenoma. It is the most common cause. 85% of the time, it causes adenoma is the cause, and approximately 85% of the cases is a single adenoma. But in the 15% of cases, they have multiple glands are involved, and they have multiple adenomas. So in second picture, you can see the two glands are involved, and there are the multiple adenomas here. And then rarely, primary hyperparathyroidism is caused by the parathyroid carcinoma. So you can see in the last, this diagram is the red one. You can see the cancer of the gland, cancer of the parathyroid gland. And then sometimes there's a case is called hyperplasia. What is hyperplasia? Hyperplasia is basically the enlargement of the cell. So these are the main causes that produces the increased level of parathyroid hormone. So now let's talk about the pathophysiology. What happens when there's increased parathyroid hormone in our blood? So we go over physiology. It affects on the bones, kidneys, intestine to absorb the calcium, to have maintain the calcium level in our blood. But what happens when parathyroid hormone level is high? So when parathyroid hormone level is high, it inhibits the osteoblast activity and stimulates the osteoclast activity. So we talk about two cells, osteoblast. So this osteoclast activity increases, leading to the bone breakdown and calcium release. So, and this is how it affects on the bones. And in the kidney level, what they do? So parathyroid hormone increases the calcium reabsorption and blocks the phosphate reabsorption from the tubules. So this is the action of the parathyroid hormone on the kidney tubules. So this is how it acts on the kidneys, and it also acts on kidney to stimulate the formation of vitamin D as well. So circulating parathyroid hormone targets the distal convoluted tubule and collecting duct. As I showed you the anatomy of the collecting duct, first I showed you the Bowman's capsule, then a proximal convoluted tubule, then loop of Henle, descending loop, ascending loop, then there was a distal convoluted tubule, then at the end there was a collecting duct. So this is where it acts. And so what it does, it increases the absorption of the calcium reabsorption. So parathyroid hormone decreases the phosphate reabsorption at the proximal convoluted tubule. So now you understand, for phosphate, parathyroid hormone is acting on the proximal convoluted tubule, but for the calcium, it working on the distal convoluted tubule and the collecting duct. So because of the two adenomas or hyperplasia, if there's a carcinoma, so normal feedback of parathyroid hormone production by the extracellular calcium seems to be lost. So this diagram, I will show you how it happens in hypercalcemia. So the chronic extensive absorption of calcium from the bone caused by excessive parathyroid hormone can result in the osteopenia. What happens? Because I told you the parathyroid hormones increase the osteoclast activity. It makes the bone more osteopenic. So in osteopenia, our bones get weaker, but there is still a strong, they cannot break easily, but osteopenia is a stage before osteoporosis, that there's a bone part they can prevent, but of course there's chances of brain blockage. And then there are severe cases. So what happens in the bone? In severe cases, there's a condition called osteitis fibrosa cystica. I'll show you the diagrams in the next pictures as well. But right now, just understand the mechanism why hypercalcemia is not good for our body. So now this is how, when the parathyroid hormone goes up, calcium level goes up, and then the skeletal manifestations of the primary hyperparathyroidism include the, excuse me, there's a selective cortical bone loss and bone and joint pain. So you can relate, our patient mentioned that patient has a bone pain, joint pains, right? So other symptoms of hyperparathyroidism, I will go over the manifestations. So we know the mechanism, pathophysiology we know. So now how it manifests, what causes now we know how it happened. So what are the manifestations? So manifestations, as we mentioned, skeletal manifestations, bone pain, joint pain, can cause osteopenia, severe cases can cause osteitis, fibrosis cystica. So other symptoms, other manifestations are hyperparathyroidism due to hypercalcemia, like patient, there's non-specific symptoms like muscle weakness, fatigue, as our similar to case patient mentioned, she get tired, then volume depletion can cause nausea. In our similar cases, she mentioned she has nausea but no vomiting, but there's vomiting as well. And then there is a neuropsychiatric manifestation as well. And particularly they include depression. It can cause confusion. It can cause deficits that are often characterized poorly and may be noted in some patients in elderly population. All right, so what are the renal manifestations? So renal manifestations of hyperparathyroidism, hyperparathyroidism called hypercalcemia, called polyuria. Polyuria means you pass urine multiple times, frequent urination, kidney stones, hypercalciuria, and rarely nephrocalcinosis. So our patient, similar to case mentioned, she has pain in the right flank, the right kidney area. So when we did a workup, I'll show you how we do the further workup, how we diagnose a patient, what's going on. The patient has a renal stone. So that's why patient has a pain in the right flank area. So this is how we can think a big picture. We'll think out of the box, make a big picture, put all the puzzle pieces together, think, okay, it's not a gastroenterology, of course, all symptoms affected. So you can see how many symptoms are affected because of hyperparathyroidism. So patient has renal stones, patient has bone pain, patient has GI symptoms, right? So gastrointestinal manifestation include abdominal pain, like in our similarity case. Patient had nausea. So other are anorexia, vomiting, constipation, peptic ulcer disease, and acute pancreatitis can be one of the symptoms. But in our patient had the abdominal pain, nausea, and constipation, right? So this is how I would say, okay, right flank pain, epigastric pain, constipation. So what's going on? So now we are putting all the pieces of puzzles together to make a big picture. So we talk about the neuromuscular and psychological manifestation as well: fatigue, fibromyalgia, muscle weakness, depression, lack of concentration. These are all the symptoms. And physical exam findings usually are non-contributory. So because, as I showed you, the anatomy of the parathyroid gland is behind the thyroid gland, right? It's very small pea-sized glands. So the physical exam is non-contributory on the gland side. But of course, we can do the renal exam. We can do epigastric abdominal exam. So examination may reveal just muscle weakness and some depression symptoms. A palpable mass is not usually expected with hyperparathyroidism, as we do see in the thyroid situation. When we sometimes in the next session we talk about thyroid disease as well. So, but also it's a rare cases that we can palpate, and mainly it may indicate a parathyroid cancer if we can palpate. That means it's so enlarged, the cancer is so large in size that we can palpate. So let's go over the diagnostics. So how we'll diagnose? So in our scenario, when patient mentioned, so I asked the patient, can we do further testing? Can we do exam? Patient said yes. So let's go over the diagnostic considerations, what we do. So first of all, we do the blood tests. So in the blood test, we check all the CBC, we check the complete metabolic panel. Can we do the next slide, please? Okay, let's go over pretty quick. Please go back. I'm going to show you the slides. Yes, we talk about the osteopenia, right? So this is the normal bone. This is the osteopenia. When I told you then there's a hyperparathyroidism, when parathyroid go to affect the osteoclast activity increases, causes osteopenia. And this is how it looks like osteoporosis. So next I'm going to show you the imaging. Yes, so you can see over here, this is the vertebra X-ray imaging. You can see the dense vertebra. Over here, you can see the bone density is decreased. You can see the difference, right? It's more dense, it's less dense. Next, I will show you the renal. You can see this is the hand X-ray. You can see the less dense bone here. Next, please. So over here, this is the ultrasound of the kidney. We can see the stone. This is the right kidney. This is the echogenic area. This is the stone. Next slide, please. You can see this shadowing, this echogenic area. And this is also again ultrasound. This sector you can see this is the liver, this is the kidney, and this is the stone in the kidney area. That stone is causing the pain in our simulated case. Okay, so what we do, first of all, we do the blood test, then we go for imaging. So now, next, please. So hyperparathyroidism diagnostic test, what we do? So we do the blood test. We do CBC, we do CMP. The CMP, we check the calcium level. So calcium level will be high. And parathyroid, we also check when calcium level is high, it gives a red flag. We need to find the cause, why calcium level is high. We didn't check the parathyroid hormone at first step, right? When the results came back, then we check, okay, now we have to check why hypercalcemia. So we're thinking of, okay, we are putting all the pieces, the puzzle together, constipation, epigastric pain, and then we did the imaging to blood test, calcium level is 10.6, a little bit on higher side. We checked the phosphorus level, creatinine was good, parathyroid hormone level on the higher side. You can see the reference range, you can see the results, and we check the vitamin D level as well. So next. So after checking all the blood testing, we go for the imaging part. So we have seen that the calcium level is high, parathyroid hormone is high. So okay, the hyperparathyroidism. Now we have to see, okay, patient is complaining of the flank pain. Okay, it's the right kidney area. So I showed you the ultrasound, how it looks like. And for the diagnostic test, I will go for first diagnostic test first. We do the ultrasound. First of all, with the lab studies. So imaging studies, please move the next slide, please. And we come back again here. So this is the ultrasound of the neck. So you can see skin, this is the muscle, this is the thyroid gland, this is the parathyroid. This is the imaging study. We can go for ultrasound. Then next we can do the nuclear scan. So ultrasound is basically the neck of the neck is safe. It's a widely used technique for localization of any abnormal parathyroid gland. If it's enlarged, then we can see. And it's of course, is a high degree of accuracy as well. But it all the downside is it's operator dependent, and so its reported accuracy has varied widely in the literature. So next we have the nuclear scan. Can you please go back? A nuclear this is a nuclear scan. This is, we can see over here, the parathyroid glands here. It's also widely used technique, commonly used in the found any parathyroid adenomas we can find. And I can show you the next picture as well, how it looks like. Yes, this is, you can see over here. Then CT scan, 4D scan. Next, please. So this is a parathyroid 4D CT scan we can see over here. All right, so let's go back to our lab workup we did. Let's move back to the slide, please. Okay, so go back, please. I think next. So yeah, here we go. So in the beginning I mentioned primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. So how we differentiate? So these are all the lab testing we see in your USML exam. We have these questions comes if these are the findings, what is the primary, secondary, or tertiary. So in the primary hyperparathyroidism, we saw in the blood lab results as well, parathyroid level is high, calcium is high as well, but phosphate will be low. Why? Remember we talk about the parathyroid hormone effects on the proximal convoluted tubule to affect reabsorption of phosphate. That's why phosphate is low. And then vitamin D can be low or normal, and common causes about 85% is a solitary parathyroid adenoma is present. And then secondary hyperparathyroidism, in this parathyroid hormone level is high, calcium can be low or normal, and phosphate can be high or normal, and vitamin D is deficient in secondary hyperparathyroidism. And the common causes are the chronic renal failure can causes. Vitamin D deficiency is the cause of secondary hyperparathyroidism. So you can see primary hyperparathyroidism, problem is in the parathyroid gland. Secondary hyperparathyroidism, problem is in the kidneys, chronic renal failure, the deficiency, vitamin D deficiency. Then tertiary hyperparathyroidism, in that the sky high level of parathyroid hormone. And then the calcium level is high, phosphate is high, vitamin D is low or normal, and it's caused by the end stage renal failure when patients are on dialysis, when patient had renal transplant. So there we can see the cases with the tertiary hyperparathyroidism. All right, so this is again pretty quick, the comparison of primary, secondary, and tertiary that we just went over. I will skip that slide and let's go over, so what to do now. So next is when we find, in our scenario, so this is hypercalcemia, right? So we have to manage. Hypercalcemia can cause constipation. Hypercalcemia, a lot of other issues. So we mentioned that this diagram you can see. So hyperparathyroidism affecting the bones, kidneys, and the intestines, causing hypercalcemia and giving all the symptoms. So how to manage the hypercalcemia? So there are different ways we can lower the levels of the calcium. So go back, please. There are different, we can use the hypotonic saline. We can, in hydration, we can use calcitonin, we can use bisphosphonates, we can use corticoids. We can do dialysis. So these are all we can help to bring the calcium level down. But what is the ultimate treatment? Can you please move the next slide? So we found that patient had a parathyroid adenoma. So who is the surgical candidate for surgery? Surgery, we do the parathyroidectomy. So surgical excision of the abnormal parathyroid glands, it is the only permanent treatment. Of course, we manage the hypercalcemia with the temporarily, but of course, when we stop the medicines, the calcium level will go up again and cause the same problem, right? So we have to treat the cause, what's causing it. So it's a parathyroid adenoma. So we have to do the surgical excision of the abnormal parathyroid gland, and the surgical criteria is the calcium is when calcium is more than 1 milligram upper limit of normal. In our scenario, it was not more than 1. The level was 10.1, but in our case scenario, it was 10.6. And bone, DEXA scan. Yeah, so what patient was mentioning about the bone pain. So we can get the x-rays, we can get a patient complaining of the bones, we can order the x-rays, we can do imaging, and then patient was complaining of flank pain, we get the ultrasound of the kidneys, we saw that there's stone in there. So this is how kidney stones. So, and then when the creatinine clearance, we check if it's less than 60 ml per minute, and then there's a 24-hour urine for calcium is more than 400 milligram per day, and kidney stones and imaging, as I mentioned before, and age less than 50 years. So our simulated case, what was the age? Let's see how many of you are paying attention. What was the age of our patient? 40. Okay, good. 40. Yes, good. So this means our patient, our simulated patient, meet the criteria for surgery because patient is less than 50 years, but we have to see the other criteria. We have to see calcium is more than 1, how bad the symptoms are, kidney stones is there, right? So these are all the criteria we use for the patient is candidate for surgery or not. All right. So you guys are paying attention. I'm very happy for you guys. Keep up the good work. Okay, let's see. Next, please. All right. So last but not least, I will go pretty quick. The art of medicine, as I mentioned, Sir Osler William mentioned, practicing medicine is an art. So it's all the communication skills and how we apply the evidence-based medicine. I will go over pretty quick. I talk about it as well. So next, please. Evidence-based medicine is basically, and again, the mastering the art of medicine. We talk about bedside manners, focus on the patient, listen to the patient, build up the rapport, and they show empathy, and laughter is the best medicine. I shared in the prior session as well. When I see my patient in the morning time, I tell them, okay, it's a morning smile time, please give me a smile. So it's really a good feeling, and I also smile with them. So laughter is the best medicine. And which is like afternoon time, I say, okay, so afternoon smile time, please give me a smile. So, when we smile, our body relaxes. So it's very important to help our cortisol level. I talk about the stress hormone release, and, patients are already in stress, going through a lot. So just try to make them relax and try to understand the patient, build up the rapport. All right. So last but not least, the evidence-based medicine. So it composed of 3 components. I will go over pretty quick. So basically, it's the clinical expertise. How we get clinical expertise by experience. So when we do residency, we see these cases multiple times. We do such a hand-on practice that is on fingertips. It's like in our reflexes. Okay, patient comes in with, this is how we build our thought process. So when attending physician asks her questions, or when you will do shadowing in person, so that's why I try to make sure you polish your skills. When asked the questions, answer, please answer. Don't hesitate. This is the learning stage for you. Don't worry what's wrong and right. Just try to answer. Build up your skill to ask the questions and answer if someone asks you the question. So it's clinical expertise. How we get it? By learning. Add mentor in your life. As much learn experience as much as you can. Online shadowing, in-person shadowing, whatever is available to you. So, and then best research evidence. We can find resources like PubMed is the best resource, and UpToDate is a resource. We can use those to keep ourselves up to date. And then we need to understand the patient values and preferences as well. So we discuss all the care plans. So patient is a part of the team. So when we talk about the team care, teamwork, doctor is a T is a team. So patient is a part of the team, right? We have to involve, we have to listen to the patient. We need to listen to their culture values. We need to understand their preferences. And we have to give them best possible patient care advice, and then patient have to decide. So these are all evidence-based medicine. Is a very important to understand that always practice evidence-based medicine for the best possible patient care. All right, so now I will go over medication prescription. Whenever you prescribe any medicine, just think what's going to happen. Will change the symptom of the patient or not? Like in our case scenario, patient has some indigestion, patient has some constipation, patient has a all the pain as well. So we have to manage those symptoms as well. And then will that change the natural history of the disease? And will that change the mortality? So these are all things keep in your mind, and whenever you prescribe, because medications are not benign. So we have to choose wisely whenever you prescribe any medicine. All right, so next, please. So these are all the resources we use up to date. And then US Preventive Services Task Force, they have very good resources, choosing wisely. Then next, CDC guidelines we follow. Then next we have, I will skip this, move on, please. Next, success. Again, everyone has their own definition of success. So you define your success definition for yourself. What is a success definition for you? For me, what makes me feel good? What makes me feel content to help others? Because we have a lot short. What is life? Life is a time period given to us from birth to death. It's a limited time period we all have. So why not do something that can help you and help yourself, get and help others as well? So when you are able to help yourself, when I mentioned about the self-care, about your well-being, so keep up with your health, keep up your well-being, and then start paying back to the community, start helping others as well. Think out of the box. So like someone mentioned, like life is like an ice cube. It's melting every day. It's melting. So why not put in someone else's glass of water, make their glass of water cold, make them comfort, make their life easy, right? Add value to someone's life. So just define your goals, your vision, your passion, and find your why and move on. Last but not least, I will just go use my last slide, keys to success. Again, pretty quick, be proactive, plan ahead. Practice, everything is practice. There's no magic in this world. Practice, 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 prioritize what is important to you at this point. Time management, perseverance. I can tell you, perseverance, never quit. Whenever you plan to quit, ask yourself why you started first place. Okay, it will give you, and think about your passion and never give up. And of course, a plan to do some clinical jobs, some internships. I know it's a little tough during this pandemic time, but keep trying. When you keep trying, there's a very good book, Secrete, Rhonda Byrne mentioned law of attraction. All the universe start working to help you. So stay positive, be focused, be persistent, and you will find something in person as well. But keep trying, all right? And I hope it will help you. Thank you, everyone. I wish you all very good luck. And I would like to see if there are any questions for me, and then we'll wrap up. All right, so let's see. Okay, I think I took too much of your time this morning. So please stay focused, find your passion, and best of luck, everyone. Thank you.
Thank you very much, Dr. Cheema. We really appreciate you taking the time to answer, our questions in the chat box and taking the time out of your day to mentor us. And I love everyone to please give a warm thank you in the chat box, Dr. Cheema, for this incredibly informative session. Thank you. I see them in the chat box. All right, now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live. You need a 70% or higher to pass and receive certification. The chat, it's in the chat right now. It's linked there. And also many of our students have expressed interest in pursuing a leadership position in teleshadowing, whether it be with live streaming or our Campus Ambassadors program. So we actually have this rolling application for our leadership application for students interested in joining our team as well. And that is in the chat box now as well. And now on to our future session dates. These dates are going to be posted on our social media outlets, and so be sure to follow us at TeleShadowing. And our next session will be next Saturday, March 12th at 10 a.m. Eastern Standard Time with our physician mentoring us in OBGYN. Thank you so much, everyone, for attending today's session. We hope to see you in upcoming sessions. And this concludes this week's shadowing session. Thank you.